Hi, everyone. Welcome to our Corporate Experiences STEM series featuring a virtual field trip to Pathways Home Health and Hospice. My name is Dee Dee, and I'm your host from Wender Weiss Foundation for Children. I am partnered with Pathways and Dignity Health Sequoia Hospital to bring you this event. And let's get started. We're going to begin with a welcome and introduction to Pathways Home Health and Hospice with the area director and registered nurse, Mr. Andy Robinson.
Hi, my name is Andy Robinson, and I'm the Area Director of Operations for Pathways Home Health and Hospice. Pathways has been in the Bay Area since 1977, serving patients in 5 counties: San Francisco, San Mateo, Santa Clara, Contra Costa, and Alameda. We provide home health and hospice services, which means we send nurses, therapists, chaplains, social workers, doctors into the patients' homes. Today, we're in our Sunnyvale office, but we also have offices in South San Francisco as well as Oakland. I'm really excited to be here with you today, and let's take you around our office and show you some of our staff, some of the things we do, and we'll teach you about home health and hospice. Now I'd like to welcome you to one of our provider areas. Throughout the day, clinicians will come in to get any necessary updates or training that they might need to do their job successfully. One of the things that we pride ourselves on at Pathways is our high-quality clinical outcomes of our patients. To ensure high-quality outcomes, it's really important for me that our staff have the education, training, and resources that they need to be successful. One of the biggest takeaways I want you to leave here today with is that we employ all types of people here at Pathways, from physicians down to clerical positions within our office. Every person on the team has an important role to ensure that our patients are taken care of at a high level. What you'll see in this room here today is different training and educational materials that we make available to our staff to ensure that they know what it is that they're doing when they're out in the patient homes. Today you'll see different types of wound care boards. You'll see pain management and safety updates. You'll also see any regulatory or clinical changes that have taken place in our industry over the past month, the past year. Again, it's really important that our clinicians know what it is they're doing when they walk into the homes. Later today, you're going to meet some of our staff. You'll see some of the competencies taking place, some of our lab work, our mannequins, as well as some personal interviews with some of the employees here at Pathways. We have a home health aide that you'll meet today, a scheduler, as well as a couple nurses. I couldn't be more happy to introduce you to them and let them tell you about some of the things that they do each and every day here at Pathways. So one thing that's really important for me today as we teach you about Pathways is that we also fundamentally explain to you the difference between home health and hospice. Home health is a service line in which our staff intend for our patients to get better. Hospice is a service line in which we anticipate death of our patients. We're really there to support them at the end of life, to ensure the highest levels of quality and dignity that that patient can have as they progress along their journey. What you see behind me here is a wall of remembrance. One of the most powerful things we do is remember those that we've served. We support our families for up to 13 months. We support community members that may need bereavement services. And this is just one small group of people that we've served in the past year. One of the most special groups of people we have here at Pathways is our group of volunteers. Pathways has about 200 volunteers, from high school students to adults that support our patients and our community. There's all sorts of different things our volunteers do, from interact with patients to support us here in the office. If you're interested in any volunteer activities, it's important for you to know that Pathways does support high school volunteers. Volunteers receive one-on-one training and support throughout their time with us, and we'd be happy if anybody wanted to join the team. As I mentioned earlier, we have several clinicians in the office today performing annual competencies, which really just means we're ensuring that the clinicians have the basic skill set that they need to provide high-quality care to our patients. In this room, you'll see Jody and Arlene, who are performing IV skills competency, which is one of the things we do almost every day at Pathways. And now I'd like to introduce you to Daniela Mak. Daniela is our clinical educator. She ensures that all of our clinicians, from our home health aides, our nurses, our social workers, our therapists, to our physicians, have all the training and education that they need to be successful. Hi, Daniela.
Hi, welcome in.
Hi, my name is Daniela. I'm the clinical educator here at Pathways. My role is to do education and training for our new staff, as well as ongoing training for our staff here in Pathways. My mom was actually a home care nurse before she got sick, and so when I was younger in the middle school time, I was able to volunteer at her workplace, see what she does, and as well as help other patients that she worked with while volunteering there. As the clinical educator, part of my job is to make sure that the new staff are trained in their skills, as well as our ongoing staff are also trained in their skills every year. This skill that we have here is called the venipunture, also known as blood draw. Yearly, we train our nurses in this skill to ensure that they are performing this skill safely on the patients out in the homes. At this time, I will reapply my tourniquet and find my veins again. Then I will take my alcohol prep pad and make sure I clean the area very well to ensure that patient has a clean surface prior to me puncturing the site. When we are ready, we're going to take the needle. This is called a butterfly needle because it looks like a butterfly. I'm going to hold it right by the wings there, remove the sheath. Then I'm going to pull the skin taut. The bevel will be up on the needle. Then I will go around at 30 degrees and I will puncture the skin. Once I see some blood, I am going to engage the vacuum and I will get blood. Once I have received enough blood, then I will release the tourniquet and I will get my gauze bandage ready. And I will go ahead and apply pressure to the site as I remove the needle. Once I remove the needle, I will engage the safety. Engaging the safety is very important on the needle because we want to make sure it does not poke anybody else. Then I will discard this into the sharps. And after I get my blood sample, I make sure I label my blood with the patient's name and date of birth, and then the time and date I collected the blood, and I will send it off to the lab. What inspired me most to get into this field, there was a particular patient that I worked with a couple years ago. He was a younger patient, a young dad of young children, and he had terminal cancer. And so as a result, one of his wishes towards the end of life was really to leave a lasting legacy for his children. We had a Christmas card design contest that year, and whoever was picked the winner we got to use their Christmas card design to send out to other staff members as well as family members from our company. And so him being a former graphic designer, he designed a Christmas card and entered into the contest. He ended up winning the contest, and his card was chosen as the top Christmas card to send out to patients and families that year. He ended up passing away shortly after, but what touched me the most was his willingness and longing to do this to leave a strong legacy for his family. Despite that he was sick, he still wanted to do something that was inspiring to the community, inspiring to our patients and other family members. And that really touched me, that as a member on the team for hospice, we were able to work together to help him fulfill that wish. Now we will transition into our blood pressure taking station. In this station here, we train our new staff. That includes our nurses, physical therapists, occupational therapists, and our home health aides on this skill. We also test them annually on this blood pressure skill as well. I have here my colleague April, who will be helping us out today. First, I will hand sanitize. Then, of course, I would introduce myself to my pretend patient. April, thank you for being here today.
You're so welcome, Miss Daniela.
I'm going to take your blood pressure today. Is that okay?
Absolutely.
All right. Which arm would you prefer?
How about this one?
All right, perfect. I'm going to set her in a comfortable position, and I'm going to wear my appropriate stethoscope, which we use to hear the heart sounds, and we also hear the blood pressure sounds when we apply the blood pressure cuff. This here is our blood pressure cuff. There is a specific artery marker, so her artery runs along the inner side of her arm here, right there. I'm going to align the arrow with that artery mark and snugly apply the blood pressure cuff. Then we have the dial here that reads the blood pressure, and this device here pumps up the cuff here so it tightens it, so when I release it I can determine her blood pressure. I'm going to put the stethoscope in my ears and we're ready to go. Alright, relax and take a deep breath here, and we're going to pump. Then I'm going to release to determine her blood pressure. Now the first book that I hear is the top number of her blood pressure. Then when I stop hearing the sound, it's the bottom number of her blood pressure. So April, your blood pressure today was 128/80. So an excellent blood pressure.
Well, thank you.
Then I'm going to remove the cuff and make sure April is comfortable.
Thank you, my dear.
And then I'm going to clean the supplies with our wipes here and hand sanitize. And that's the end of our skill today.
My name's Andy Robinson. As you saw in the video, I'm the Director of Operations here at Pathways. Really excited to be here with you today. We have a little bit of a presentation for you for one of our most common clinical diagnoses that we see in home health and hospice, which is congestive heart failure. Today, we're just going to review. I'd like to give you a basic understanding of what congestive heart failure is, a small introduction to the anatomy and physiology of the heart itself, kind of what it's made up of, how it works, and talk a little bit about the disease process itself and how Pathways Home Health and Hospice service offerings may benefit patients that have congestive heart failure. Congestive heart failure, heart disease, is one of the leading causes of death in the United States. There's about 30% of our population will experience congestive heart failure at some time in their life. Congestive heart failure is essentially when the heart cannot pump enough blood to meet the demand of the body. So you may know that blood carries nutrients and most importantly, oxygen throughout the body. Every organ, every cell inside of our body requires oxygen to perform their function. And the heart is the muscle, the motor that pumps the blood around the body. Heart failure itself is not actually a disease. Heart failure is a clinical syndrome as a result of a disease process. Some of the most common causes, the most common cause of congestive heart failure is coronary artery disease. This is basically when fatty deposits, cholesterol, typically due to a poor diet, sedentary lifestyle, these fatty deposits build up on the inside of your arteries and your vessels that carry blood throughout the body. And when that happens, it's harder for the blood to pump through. You can think of it simply as like a garden hose. If the garden hose is clogged, it's really hard to get water to go through it. The same is true with blood inside your body. If your arteries and vessels are clogged up, so to speak, with fat, cholesterol deposits, the blood cannot pump very effectively. This causes a lot of strain on the heart, and hence, over a long period of time, that can lead to heart failure. So for Pathways, Home Health and Hospice, our role is really to help manage the disease. There are both medications, medical interventions that can help manage heart disease, heart failure, but there's also, and most effectively, a lot of non-pharmacological, non-medicine related interventions that we can help patients and families with to improve the symptoms of heart failure. So I wanted to start real quick by making sure you had a fundamental understanding of kind of the heart, its function, and how it works. So I want to draw your attention right here to number one, and we're simply just going to follow the blood along its path here. Your body is made up of arteries and veins. Arteries carry oxygenated blood. That would be these this orange color here. These are arteries. And veins carry unoxygenated blood back to the heart. Arteries, oxygenated blood from the heart, from the lungs, and veins returning used up blood, let's call it, unoxygenated, that need to come back through the lungs and get some more oxygen. And that's what I want to walk you through right here. Your heart, of course, is made up of 4 chambers, 2 atriums, 2 ventricles. Atriums on top, number 4 and number 11. Ventricles on the bottom, number 1 and number 5. Ventricles are very large. They're the largest chambers of your heart, and they're actually what pump blood out of the heart. So we're going to start at number 1. Remember, veins, blue, unoxygenated blood. We need to get some oxygen in this blood. So with 1 pump of the heart, it shoots blood up into your lungs. So your lungs' primary function is to oxygenate blood. Blood then is carried out throughout the body to support your normal function. So as blood goes through the lungs, picks up that oxygen, it comes back into the left side of your heart, which is responsible for pumping blood to the body. So as that oxygenated blood comes back in, moves into the left ventricle, and ultimately another big pump, and it's sending blood up all throughout your body, brain down to your toes. It's quite a fascinating process when you think that there's actually about 6 quarts of blood inside of you right now. And those 6 quarts of blood pump throughout your entire body 3 times every minute. So in one day, the blood in your body travels 4 times the distance across the United States. That happens every single day that your heart is pumping. So what happens with heart failure? As I mentioned before, clogged up vessels, your heart has to work a lot harder to try to get the same amount of blood throughout the body as it did prior to being obstructed. So again, simply, if the heart cannot effectively pump blood throughout the body, it backlogs, it gets congested. That's where the congested heart failure comes into play. So imagine you have a reservoir of sorts of blood here, and your heart's pumping, but it's not able to get that blood out. What happens is it congests, it backlogs. It creates an enlarged heart. As you can see here, normal size of the heart. With an enlarged heart, you see really kind of a swelling type of process. As that heart, of course, the heart is a muscle. So as the heart beats harder and harder and harder, that muscle is actually growing, which is not a good thing. You know, a lot of times we want our muscles to grow, but when it comes to the heart, you really just want it to be able to effectively do what it needs to do. Unfortunately, where the problem comes in with heart failure is that fluid backs up. And if I go back to this previous slide, if you think about it, if we're pumping blood, trying to get it out of the heart And these vessels that it's trying to flow through are congested. That backlog of fluid, of blood that I mentioned, affects your lungs. And what happens is you actually develop fluid around your lungs. And this is the most common clinical presentation that we see as healthcare professionals for congestive heart failure is shortness of breath. They're short of breath because there's fluid around their lungs caused by heart failure. So as I mentioned before, heart failure itself is not a disease, but there's reasons why somebody would experience heart failure. The most common reason being that obstruction of vessels. It's also the #1 cause of a heart attack, which we're not going to get into too much today, but you typically see these things go hand in hand. What does a patient present to us like? #1 thing is shortness of breath. Sometimes you will see their blood pressure decrease because, again, the heart cannot effectively pump, the pressure is less, you're not going to get as much fluid moving through those vessels as you should. The second most common clinical presentation that we see is the fluid buildup, not just in their lungs, which we hear with a stethoscope. You'll hear crackles and wheezes, which indicate there's fluid in the lungs, but you also see a very large abdomen. Fluid, that backlog of fluid, your blood is about 80% water. That backlog of fluid actually, your body is trying to get it somewhere. It knows it shouldn't be congesting the heart. So it does what's called third space. Basically, fluid will leave your vessels and build up typically in your abdomen, and you'll get a really large fluid-filled abdomen that at times actually has to be drained. The other most common clinical presentation are very large, red, swollen ankles. You've all seen this before, I promise you. Us nurses, when we walk through stores, we're always diagnosing people because we see things like really swollen, red, dry ankles, which would indicate that they likely have some heart failure. So how do you actually diagnose heart failure? Well, largely it's physical presentation, but there are some medical interventions like an echocardiogram, which is a Doppler type of system, chest x-rays, some other interventional radiology types of techniques, like an angiogram, which is where they actually shoot contrast into your vessels, put you under a machine, and they can see where that contrast is going. They can see where the backlog is and maybe where it's getting congested. So how does Pathways help? What do we do to intervene with these patients? Basically, we come into the homes, we provide vital services, usually medication management, symptom management, lifestyle modifications being one of the biggest and probably hardest interventions to implement is changing a diet, eating less salt, maybe exercising more. And sometimes people are oxygen dependent, so we help set up oxygen, manage oxygen in the home. Again, these are all typically new things to these patients. When we get started in home health scenario, we can also provide things like physical therapy to help work on their deconditioned status, to get them up, moving around, get out of the chair, get off the couch. Those are some of the best things that you can do to manage congestive heart failure. You may have heard this before, but if you're not using it, you will lose it, especially as your age advances. Our goal is always happy, healthy, and successful patients in the home setting. Probably our #1 goal is to prevent a hospitalization. We want to keep people out of the hospital. So we establish goals. We set up those medications. We make sure the patients and families have a good plan in place to stay on top of them. Activities of daily living. People with advanced congestive heart failure at times can barely even get out of the chair, get out of bed, and walk to the living room. They're so deconditioned, require oxygen. So a lot of times folks with congestive heart failure have additional diagnoses that we're managing at the same time. Again, congestive heart failure is a result of something. So there's almost always a root cause that we're also addressing. For home health, we typically see these patients for up to 12 weeks. Just every patient's unique. Trying to really get them to a stable, managed point of their disease, their state, and then ultimately they can stay in that, I'll call it maintained, managed state for years and years and years. The unfortunate part of congestive heart failure, as I mentioned before, it's a chronic disease, meaning you will deal with this and manage it your entire life. Unfortunately, medications and non-pharmacological interventions only go so far, and they only last so long. We intervene until those interventions stop working. And then there's a transition of care that we'll walk through here. We know when patients are progressing, meaning getting worse, when they start to have advanced symptoms, the medications aren't working like they used to, they require more and more oxygen, their activities of daily living become harder to maintain, it's harder for them to get up out of bed, out of the house. We give patients really practical tools to kind of monitor their own health status with congestive heart failure. We ask them to call us anytime they're having an issue, and we can provide early intervention, get out to the home, work with them, address the fluid buildup, and ultimately prevent that hospitalization from happening. So unfortunately, as I mentioned, congestive heart failure can progress to a point in which our interventions are no longer successful. That typically requires a much more advanced level of intervention if the patient would qualify for said intervention. And I want to walk through a couple of them with you really quickly. The first one being a coronary artery bypass graft, which is essentially those vessels that I told you about that get clogged. A cardiac surgeon, a heart surgeon can go in and help open those up with stents, balloons, to try to open up that hole to get that blood through a little more effectively. That's a very, very common procedure in the United States. As adults reach 50, 60 years old and beyond, we see coronary artery bypass grafts being done at a very high level for folks with heart disease, which again is probably one of the most, if not the most common clinical diagnosis that people struggle with in the United States. If that doesn't work, I'm going to show you an LVAD, LVAD, a left ventricular assistive device. This is actually a battery controlled pump that's surgically implanted inside your heart, and it basically takes over for the heart when the heart has progressed to such a point where it's just no longer working. So first, let's talk about a CABG, or a coronary artery bypass graft. This is that clogged vessel I'm telling you about. So a cardiac surgeon can actually get into this vessel, whether it be open heart surgery or simply through a large catheter, which is like a probe that they can feed all the way up into your heart and perform surgery right through a little catheter. We take care of these patients post-op. This is what they look like if they have the open heart procedure. They come to us with a very large incision right down their mid-chest. We provide wound care, prevent infection. These patients are often debilitated, deconditioned, require a lot of therapy services. To get up, to get out of bed is one of the most important things post-op for anything. So we provide a lot of interventions in the home setting to help take care of these patients post-operatively. I also want to show you an LVAD. As I mentioned, a left ventricular assistive device. The left ventricle of the heart, remember, is the one that pumps the blood out to the heart. This is a battery-operated pump that's surgically implanted within your body that runs on an external battery pack and helps the heart, compensate for what it can't do, which is pump that blood effectively throughout the heart. So I want to show you a picture of an LVAD being inserted surgically. Again, this is a very big procedure. Not many patients qualify for this.
But if they do, again, a cardiac surgeon opens up their chest, they go in and they install these devices, and we take care of them again post-operatively to help manage the site, make sure they have the education and training that they need to be successful in the home. There's only so many interventions you can do. This disease does transition to a point in which it's no longer curative or maintained, and it, what we call, becomes a terminal diagnosis, meaning that this is when we would anticipate the disease progresses to a point where an end of life situation is not just possible, but very probable. And that's really where we implement hospice care. As I mentioned before, home health is curative, hospice is end of life care. It's a whole different team, high quality, a lot of dignity, wrapping support around the patient and family is our mission. We do that with a team of doctors, nurses, social workers, chaplains, volunteers, again, just to wrap support around those patients. So just real quick, heart failure is one of the hundreds of diagnoses that we take care of in the home. It's a chronic condition, meaning you'll have it your entire life once you're diagnosed with it. It does require significant lifestyle changes, modifications to be successful long-term. Pathways Home Health and Hospice offers a very comprehensive medical model to support these patients from diagnosis all the way to death. We will offer some time at the end of this presentation. I'm going to share a video with you here shortly to introduce you to some of our staff, to meet some of our team, talk a little bit about what they do, some different roles at Pathways. I really want to get you exposure to some of the different professionals we have here, some of the different roles that might spark your curiosity, pique your interest. Folks that you're going to see on camera now will be back at the end of this presentation to answer any questions, have any dialogue that you may want to have.
Hi, my name is Shirley Castro. I am a Client Relations Executive for Pathways Home Health and Hospice. My job entails me to be out in the community to reach out to physicians, hospitals, skilled nursing facilities, and residential care facilities to educate them more about home health and hospice. I was born and raised in the Bay Area. I have a passion for helping people, and I've been in the healthcare since I was 17 years old. I wore many hats. I worked in a facility as a cook. I passed out medications as a med tech in the facilities. I also went to school for my certified nurse assistant. I currently now am working for Home Health and Hospice, and I look forward to working into the nursing field. So when I meet with families at bedside about the services that we provide, I go into detail about home health. Home health is just a wonderful benefit for a family member that's struggling to leave the home and that need that additional help, maybe with physical therapy, having a difficult time in walking and ambulating, a registered nurse that's able to help out with medication management. We also do have home health aides that do visit for home health that assist with activities of daily living to help out with sponge bathing, feeding, exercises, doing a couple of walks at home, or possibly just reading a book. For hospice, we do have a whole care team that's available to go ahead and take care of your loved one till the end of life. That touches home for me because I wish I knew more about hospice when I was 17 years old. I lost my dad at the age of 17, not knowing about the services that were out there. And that was just my mission and why I got into home health and hospice, is to educate families about the wonderful service that we provide. You have a registered nurse, a hospice medical director, a social worker for counseling and support for the family, not just the patient, but for the whole family. You also do get supplies that's needed, like a hospital bed, a walker, oxygen concentrator. And those are just some wonderful things that's covered under hospice that sometimes a struggling family cannot afford. What I could remember growing up and what got me into the industry was when my mom worked at a facility. Soon thereafter, I ended up cooking in the same facility that my mom cooked in. And that kind of triggered me to get into the healthcare field. So I ended up becoming a med technician distributing medications to the residents in the community. So as a med tech, the facility was able to support me and have our nurses do on-site training. I was kind of the right-hand nurse of the LVN, and that entails, writing down medications, the frequencies, the doses, and making sure that they get their medications routinely and frequently and make sure that they're correct as well. So working as a med tech inspired me to want to become an administrator to manage my own facilities. And then as an administrator, I was able to go ahead and complete 80 hours through community care licensing to achieve my administrator license. From then on, I managed 2 facilities, a 55-bed capacity facility for Alzheimer's and dementia patients, and then also another 55-bed capacity facility, which has residents that are ambulatory, that are able to ask what their needs are, and just kind of be there as their family. And that's when I decided to go into home health and hospice. I thought about my dad a little bit more. I was able to go ahead and get my certificate through another agency that was able to help me get my certificate and become an executive in sales. What I like most about my job, I get to work with different people every day. And when I say different people every day, I get to walk the hospitals, meet new doctors, meet case managers, meet patients at bedside before discharge. I'm able to meet social workers and also family members that are in need of more education about the services that we provide. I also get to work with passionate people that are just as passionate as I am about what I do in my line of work. That's what made me realize that I really love what I do, and hoping the next journey would be going to school for my nursing.
Hi, my name is Lyndon Rumor, and I'm from Pathways Home Health. I'm a home health aide, and I, of course, have been a nurse for the last 12 years. I've been here for the last 9 years. Grew up in the Philippines. I came here when I was 3. I live over in Santa Clara now. I, of course, love the job I do, and you meet so many different people. I, of course, went and got my HHA, which is a home health aide, and I went to school for that, and that was only about a day class. And on that note, I'm doing this now at this company for Pathways, and we, of course, go to people's houses, go to people's facilities, and we take care of people who has dementia, cancer, and congestive heart failure. For my home health aide, what I do on an average day is that I help out with the patient. You just have to give them a nice clean bath in bed and change all the sheets and change them, make sure that they're perfectly clean. When you go to these patients' houses, you can look at it as you're going to be seeing these patients for quite some time. Now, if they, of course, have cancer or so, it's kind of heartbroken. But then again, when you go there and you give them your smile and just to be there to help them out and just chat with them, it takes everything away from them for at least about a good hour and some, and it brings a smile to their face. And of course it brings a smile to your face because you're helping them out. And again, you can learn a lot from people. I went to one patient, and he, of course, was a teacher too, and he, of course, we'll just chat about everything, and we'll just talk about his family and his kids. He was really good on sports. He loved the basketball teams, and we'll just talk about sports for like, did you saw that basketball game the other night? And at the very end, he'll just turn around and say, well, I will be happy to see you again in about a couple of days. But then again, the longer you have them, it's almost going to be like a family if you look at it, because you would have to take care of your own family like that too. In 2010, I decided to go back to school. I went for my certified nursing assistant, and I got that license. The CNA training is about, if you do it during the day, it's about a month. If you do it on the weekends and evenings, it will be about 6 weeks. A home health aide is only for a day, and there's not only that, but you can also get like your physical therapy license, occupational therapy. I of course have my assistant for rehab, so that's what kind of made it easier. So I do plan on going back to school for my PT. I do encourage that kids who are in high school go into this profession, and you can do whatever besides being a certified nursing assistant, a home health aide. We have all kinds of positions that you can do, whatever your passion would be. Medical records, coding, surgical doctors, LVNs, RNs, who are registered nurses, and be around a lot of people and help and give back to the community, and also help out in your own families.
Hi, my name is Veronica. I am the supervisor of office operations here at Pathways, and I oversee our scheduling department, medical records, intake, and our reception desk, as well as our medical supply. In a brief summary of my job, I am a Sunnyvale native. I went to high school at Homestead. I grew up with my dad in a single-family home, and after I went to Homestead, I went to a vocational school called Everest College, which was at the time in San Jose. I went for a medical assisting. So that was a year-long program, which I got to learn medical terminology. I got to learn how to assist the physicians, as well as give injections and take injections too for my classmates, which it was a really good experience working as a medical assistant. During that time that I went to school, I was working as a retail associate. I worked as a receptionist at a day spa, and then I worked in sales as well. So right after I graduated from school, I went and did my externship at a pediatrician clinic. After I completed my externship, I immediately got a job at a weight loss facility a few months after I completed my externship. I've worked for a sleep and pulmonary specialist, as well as Palo Alto Medical Foundation. I loved working with patients in all of those places, working for physicians. I landed my role at Pathways, which I was temp for about 6 months from a temp agency. During those temp times, I worked as a team support coordinator, which that's faxing, that's answering phones, working with the schedulers, scheduling appointments, and then working in medical records as someone who would file paperwork. And then I became permanent after 6 months, and I started off as a clinical operations admin assistant. Shortly after that, I became the lead admin assistant, which was in general the same type of role. It just was more of a management standpoint. Now I am the operations supervisor, which I love my job in its entirety. You know, I'm doing different things daily, so it makes for an exciting work day. I definitely would recommend, if anyone is trying to be in a leadership position or trying to be in the healthcare role as a supervisor or lead, I like the people that I work with, and just being their leader and always being there to support my team in anything that they need is definitely rewarding for me working for a home health and hospice agency. what recommendations do I have for high school students wanting to be in the healthcare fields? And I would definitely say a counselor or an advisor to help you in the next steps, and what classes you need to take to become a medical assistant. You know, it's always nice to start out in a specific position, and then you can definitely go, move up, and then eventually do what you truly feel is right in your heart to do. I would definitely recommend getting financial aid. It will help you to be able to pay for classes, pay for books, and then also, what helped me too was having jobs that I did. I worked for Singular Wireless, which was a cell phone company. I worked for Harmony Day Spa during my times as going to vocational school. I think, it had led me to the path that I'm on now, working here at Pathways. So I definitely am blessed to be here working for Pathways.
My name is Sonny, one of the nurses here at Pathways. I've been here for 9, going to 10 years now. I enjoyed what I do. I started off in the health care sector when I came to the United States of America. I started off making beds. I was a bed maker in a facility, and then moved on to being a CNA, which I did for a couple of years. With the background of my elder siblings, they were both nurses. They inspired me to get on the same journey with them, because at home they will be using all these big terms, medical terminologies then. And I just want to be part of that conversation. So I tried and started school focusing on being a nurse. I started with all the prerequisites that was required, because my original background was business. I started at Mission College, took all the prerequisites that they needed, and then moved over to a medical institution by the name of IME. I think it closed now, where I did my my nursing studies and took the board and passed. Some of the things I like most about being a nurse is the relationship that I built with this patient over time. Most of them are old, and you think they cannot remember stuff, but they do. They might not remember your name, but they do remember your compassion, your care, and the good things that you do for them. Being in Pathways is just a place that I think is good for me. Yes, the career is rewarding. I love it here. My typical day is quite okay. Get to the patient's house, make sure everything is okay. Make sure they're not in pain, because that's what I do. We provide optimal comfort. Make them laugh, of course, make them laugh. Because it's not all about giving meds or pushing meds. You have to develop a relationship between them. And my own way to develop a relationship with my patient is to make jokes. And once I start doing that, then I get them. I was having a certain patient at Portola Valley, and it doesn't care what the day is, as long as I'm there, it's fine, because he knows I'm going to give him one every time. So as soon as I'm there, he will just start laughing, and the wife was there, the family was there, and as soon as I get there, it doesn't feel like I'm walking. It's like I'm in a family reunion, and I'm going to stay there for a couple minutes, then I'll leave. Basically, it was brain tumor, which eventually he died of. The little obstacle that I might have with some of these patients is if they're new to me. I have to find that common ground. So I have to understand the family dynamics. All family are different. You will get to some homes, and the patient is there, the siblings is there, but the communication is not there. That's tough. I try to normalize whatever it is and do what I do and try to let family know that this is just why I'm here, not for anything else. I want to see my patient quite comfortable. We basically deal with comfort medication. We don't want to see you having pain. We don't want to see you being restless. And we don't want to see you having difficulty breathing. And with those three symptoms, we deal with morphine, we deal with lorazepam, we deal with Aldol, we deal with iothiamine, which is good for circulation. We deal with Senna, because once you're on opioids, you're prone to being constipated. So those are the meds basically we give. I like meeting people. I like making lives better. I like helping people. The medical sector is the best place to be. And if I can recall, at the age of 3 years, I was diagnosed with hernia, which I was admitted for, and they did the surgery. The comfort that they showed me helped me heal even faster than I think the medication that were given me. It was in the back of my mind that, if I have a way to do this, I'll be that help to somebody else. And eventually, I'm here and I'm doing it.
Hello again. As I mentioned before, my name is Andy Robinson, and I'm the Area Director of Operations for Pathways Home Health and Hospice. What I'd like to do is just tell you a little bit about myself, both personally and professionally, and why I love healthcare so much. So I grew up on a farm in southeast Nebraska, went to a K through 12 school of about 60 people in my class. I am the middle of 5 blended adopted kids. I have 2 older half-brothers and 2 younger half-sisters. After I graduated high school, I moved to Lincoln, Nebraska, about 40 miles away from where I grew up, and really started school and started working right away. So my path to becoming a registered nurse really started as soon as I graduated high school. I almost immediately moved out of my house, my parents' house, and started just through an online search, looked for home health aide courses in the town that I lived in. I found a 75-hour training program in the back room of a library. I knew I needed to work. I knew if I wanted to go on and become a registered nurse, I needed to be able to afford college. So I found the courses to become a home health aide, was able to complete that in about 6 or 7 weeks, and found a job right away. I think one of the beautiful things about healthcare is while you're in school and getting the training that you need to become whatever level of employee in healthcare that you're trying to become, is you're exposed to all the different sites through your clinical orientation. So healthcare school is really a lot in class lecture, but it's also out in the field, so in hospitals, in clinics, out in the homes of patients. And that's really how I found my first home health aide job, was through my education. Pretty much immediately started working and simultaneously getting my associate's degree in nursing at the same time. So one of the great things about healthcare too is there's multiple shifts available. A lot of times I worked at night and went to school during the day, and that cycle really repeated itself over several years until ultimately I was able to achieve my registered nursing degree and started working in the hospital right away, and then just continued my education from there. There's so many things you can do in healthcare and in nursing. You can literally work almost anywhere, and there's such a shortage of nurses in the country right now that the job will also take you anywhere you want to go. I'm proof of that. Coming from a farm in Nebraska, kind of the last place I thought I'd end up is in the Bay Area in California, leading an organization as strong as Pathways. One of the most important things for me was a strong support system. I made sure to have really positive influences around me that pushed me to excel and supported me along the way. For the first few years of my career, I literally lived in the basement of some of my family members' homes, and just worked hard and went to school, and ultimately that can lead to a lot of opportunities for you. I think what I like most about healthcare is just supporting people. I really enjoy helping people overcome challenges. I think as a middle child, naturally that was my role in my family, and I'm really surrounded by caregivers. My mom, several of my aunts and uncles are in healthcare, and I just absolutely love what I do. Being able to intervene with individuals and support them during difficult and challenging times is really what fills my cup. I think one of the best recommendations I might have for you if you are interested in healthcare is just simply get some exposure. Through a volunteer activity would be a great idea. Talk to people that are in the field. Talk to nurses, talk to home health aides, physical therapists, understand what they like and maybe what they don't like about the career. And then ultimately just dive headfirst right in there, get the exposure and see if it's something that you enjoy. As we've shown you today, there are entry-level jobs, office clerical jobs, all the way to skilled level positions, nurses, physical therapists, occupational therapists, all the way up to being a provider. You can do anything that you set your mind to with hard work, dedication, and a lot of focus.
There are a lot of jokes you can do with this older folks, but you have to be mindful. It has to be respectful. One of my most common jokes that I do, mostly on males, during blood pressure checks and all, I'll put a cuff around their upper arm and I'll be like, "Ooh, Mr. Smith, your arm's so big. You've been pulling some weights." Then, that creates some laughter. And from that point on, more jokes might come in and, the relationship get more tighter. Thank you.
I appreciate the long list of questions that we received from the group. I'm going to start with the most interesting question that I think we received, which I had to Google research. It's a fun one. When were wheelchairs invented? So I had to look this up. The first documented wheelchair was in 1595, but there are literally stone carvings of wheelchairs dating back to ancient times. So I imagine many, many years before that, but the first documented wheelchair was in 1595 in England, for what it's worth. Okay. Daniela, I have a question for you. Couple questions for you. What has been your biggest or scariest mistake you've ever made as a nurse?
That's a really good question. I had to really think about that one because definitely mistakes have been made before, and just thinking about the scariest mistake. There's probably a couple that I could name up. The first one would be getting my first full-time job. I think that transitioning out of college, where you're in a very protected environment in college, learning, and then I was also very, I think, naive and innocent. And after almost a year of searching, I landed upon my first job as a home health nurse. So I started off visiting patients in their homes, and little did I know that it involved a lot more than I expected. And so I wouldn't say it was necessarily a mistake, because it ended up being fruitful thereafter, right? Being a home visits nurse thereafter had me involved in home care and then in hospice, and then eventually transitioned to management, and then now my role as a clinical educator. So though it seemed like a mistake in itself in the beginning, I remember after quitting that job, I told myself I would never ever get back into this field again. Little did I know that less than a year later, I would jump back into it. And so the mistake was providential and a good thing in a sense. I learned from my mistake that it wasn't really a mistake, something that was on the right path, though in that time, I didn't seem like it was on the right path. I guess on contrast with that, my biggest mistake was probably quitting my home health job and going into working at a clinic that I thought was going to be easier, less hours, less of a commute,
when in reality, that job was actually not for me. So the easier way isn't always the best way, is what my advice would be. Sometimes having it be scary or hard is maybe the better way to go.
Thank you. Veronica, the next question is for you. How has working through the pandemic affected the way you and your teams work?
I don't think it's affected us in a negative way. I feel like it has helped us to focus more on the workflow coming in. So I don't think it's affected us in any negative way. If anything, it's just helped us be better at what we do, and help us, be focused without all the distraction, of others, being around, basically.
Yeah, great. Thank you. Sunny, next question's for you. And take yourself off of mute. What is the hardest piece of equipment or hardest skill you've ever had to do as a nurse?
Can you hear me, Andy?
Yep.
I would say the transfer board. That stuff never worked for me. I don't know how it works. They used to use it back then. I don't know if they still use it. I don't know if you know what I'm talking about. The board that you use to transfer a patient from the bed to the chair, or from the chair to the bed. It never works for me. I would say that's my biggest or my hardest equipment ever.
Yeah. Yeah, I would agree, Sunny. Transferring patients is one of the hardest things that we ask our clinicians to do. They've really tried to invent many different tools over the years to help with transferring in the home. So I can definitely relate to that one. Shirley, how long was your journey to get to where you are right now?
Oh my, very long. Started off during high school when I was 17 years old, wore many hats, but didn't take me too long to decide that I wanted to get into more of the healthcare field and sales and be more of a resource for the community, for home health and hospice.
Okay, thank you. My next question is for Daniela. Other than morphine, what are some of the common medicines we use to help patients manage their pain and symptoms?
That's a really good question. Besides morphine, in hospice, there's a lot of different medications we can use for pain. Sometimes we can use something as simple as an over-the-counter Tylenol or Motrin, Advil, aspirin, if that helps relieve the pain. But we're very careful in how we do it. We have some more complex medications. Even something like morphine, we always start with, the lowest dose we start at is 0.25 mL, which is like this much. And we usually give it about every 4 hours as needed. If they need more pain management, then we can increase the dose. There's also a lot of different varieties. There's a whole cocktail of medications that we can give to help relieve pain and comfort.
Yeah, thanks, Daniela. I've got Lyndon in the office with me. I think one of the more difficult questions that we received, and kind of a personal one, is, how does it feel? What's kind of that emotional response when you know the patients you're taking care of and developing connections with and relationships? How do you handle that emotion when you know they're going to die? And I'll kind of answer some of this too with Lyndon, but you want to kind of tell them how you process that emotion and deal with it on a day-to-day basis.
On that note, for handling that kind of emotion is really kind of hard, because you do have that connection with the patients, and in that motion, when you see that patient every day and you know it's just going to end up happening, it's almost like family, basically. And I would say in this kind of position and profession that we have, it kind of helps out with your own family in a way, because you can see it coming compared to like when you don't. You, of course, have to handle it in a good way and support the family who, of course, will be going through it. I had people on my shift that has happened that way, and I, of course, just helped them out during that time.
Yeah, I think one of the more difficult things, just like anybody that's experienced death and dying themselves, every member of our team, our family, grieves differently, just like every member of your family would. If you've lost a grandparent or a parent or someone close to you, you've experienced that firsthand. As a team at Pathways, it's really important for us to support each other through those times as well. Hospice especially is a very emotionally taxing job, as well as physically taxing. So it's really, really important that we practice self-care. We have a great team of social workers and chaplains here that really, no pun intended, preach that to us and really help facilitate different types of platforms for us as a team to be able to grieve and process those emotions as well. Lyndon, while I've got you here, one of the questions was around your CNA training and then what it took to become a home health aide. So could you clarify the route that you took to become a home health aide, which I believe first was get your 75-hour CNA and then your home health aide?
Yes. The CNA, we have, of course, you take a class, and now it's like, I've been in it for 12 years, so that's how long I've been that CNA. You can take that class first, which is, there's like 3 parts to it. You can either do it during the day, which is like 8 to 5. You can do it at night, which is like 3 to 8 or so. And then on the weekends, which is usually 8 to 5. On the CNA part of it, if you do it those times, you can, during the day, it'll be like a good month. Both the weekends and the evenings will be probably about 6 weeks. And then for the home health aide, it was only like a 1-day class.
Yeah, great.
So,
that's great, Lyndon. Thank you. So yeah, just in summary there, to become a home health aide, you first have to become a certified nurse's aide, which is a 75-hour course. Lots of platforms offer that. Lots of educational institutions offer that. And then you can advance from there, as Lyndon and many of our team members have, to become a home health aide specifically, which is a little bit of an additional training. We do have some questions coming in the chat that I'll parse out next. Grace has asked, how challenging has it been to provide care during the COVID lockdown? And specifically, how did it affect patient interaction? And I can take this one because it's kind of a layered response. Shirley, who works in sales and marketing, works within the community, our hospitals, skilled nursing facilities, doctors' offices, and ultimately we basically saw them shut down, not allow any visitation, even for family members. So it was extremely hard up front to even be able to get in and educate folks about our services. And I know Shirley could attest to that. But then when we did get patients on service, kind of depending on where they were, whether they were at home, a skilled nursing facility, there were a lot of changes to the way we interacted. None of them favorable. From face shields, masks, gowns, gloves, booties. We looked like a hazard team coming in to just simply take care of you. That was a challenge. Many facilities that we work in would not allow certain disciplines. We, at a time when we could provide patients and families with nurses and chaplains and social workers and aides and nurse practitioners and volunteers, all of a sudden it became only nurses and maybe once a week. Some patients had to actually be discharged because they wouldn't let our care team come in the facility any longer. It was extremely challenging, emotionally difficult for our team that's established these relationships with patients and families, and then unable to provide them with that level of interaction that we are used to. Jaden has asked, and I'll ask Veronica to answer this one. What's been your inspiration to work for Pathways and in healthcare?
In healthcare in general, I feel like I've always had a good support system in my family. My dad's always been so encouraging
so inspiring, especially in the field that he was working at NASA for many, many years. You know, just inspired me with his work ethic to be able to do something such as healthcare. You know, I loved working with people. I was such a people person, you know, seeing with clients. And it also, you know, it challenged me in many ways, you know, to be better at, you know, being a medical assistant and seeing these patients. So healthcare just really kind of opened my eyes, you know, like when I went to job fairs and I was looking into medical assisting and working in healthcare. It's just always something that I was kind of drawn to. So definitely my inspiration came from family, came from good support system around me always, still till this day.
Great. Thank you so much. I will I'll answer a few of these additional questions just to keep us moving along. One of the questions we got was, do you ever get emotional with your patients? Do you step out of the room if you get emotional, or do you get emotional with them? You know, kind of to each their own. Our team members here are very passionate about what they do. I know for a fact that our team does get emotional with patients, with families. Again, they become kind of family by proxy. So I absolutely encourage it. What we do here is very real. We are humans taking care of humans, and those emotions are very real. We do get emotional with our patients and our families. Another question we received was, does hospice care for kids? We absolutely do. Pathways specifically does not have a pediatric hospice program. We have before, but currently we do not. But many of us on this call have been part of pediatric hospice programs, whether at Pathways or previously. As you can imagine, that is a kind of a subset of its own in our world, in hospice. That should not be happening, right? It's a very difficult situation. The family dynamics are quite unique, but we do ground ourselves in the principle of what we are here to do. Our mission is to serve patients and families at a very high level, whatever it is they need. So those are very, as you can imagine, very difficult situations. What we do see currently is a lot of kids that are losing a family member, that are losing a parent or losing a grandparent. And we offer a comprehensive kind of grief and support service to all of those individuals. So that, I think, addresses that. Another question we got that I thought was interesting is, what's your work-life balance like? So I'll take this one. On a personal note, you shouldn't ever expect a work-life balance. That would indicate that you have two lives that you're trying to balance out. That's not the case at all. If you work in healthcare, it's a lifestyle. These jobs don't just shut off when you go home, and you don't just turn them on when you start your shift. You have one life. As a director here, what I really want the team to strive for is personal and professional satisfaction while maintaining that one life that you have. It's harder some days, some weeks, some months than others. But I think everybody at Pathways and everybody that gets into healthcare, and certainly everybody that stays in healthcare, understands you're not an 8 to 5 employee. You know, you might have a shift from 8 to 5, but you think about these patients when you go home. You think about the families when you go home. You lend and extend your own life to theirs, and they do the same to you. So really what you should strive for, and I would encourage all of you as you are graduating and looking for jobs, and even now in high school, strive for satisfaction in both your personal life and your professional life, whatever that may be, because ultimately that will lead to sustainable success, and set your expectations a little bit more realistically. So that would be kind of my best advice for the work-life balance question. I'll pause right here, turn it over to Dee Dee and we'll kind of round out the presentation for today.
Thank you so much, Andy. And thanks to all of you for being here with us. I'm going to go ahead and share for you the final survey. We really hope that you have enjoyed being with us and meeting healthcare professionals who love what they do and learning about careers in home health and hospice that are accessible and available to you after high school. In fact, are highly in demand. We actually have a handout that I will provide with Mrs. Spencer that has a list of other healthcare professions, including home health and hospice roles and the training that's available, much of which is free training that is now available for all of you. Last but not least, thank you to all of you wonderful students for engaging with us today and investing in your career education. That's all from me.